Morning, my colleagues. This is the second one-to-one exam scenario of FRCR-Viva session. Uh, Today, we'll give opportunity for three candidates. Each one will take 15 minutes. Dr. Nagam was take time out for us, please. 15 minutes
Okay.
shortly, short step us. And after 15 minutes, I will comment. The value of today is to simulate the exam. Is number one. Number two, when you take many cases, the fluctuation of stress and different systems of radiological examination may affect your answer. So I want to give you some tips and some experience about how to overcome this frequent normal exam situation. Um, my advice is to the three candidates before start, don't worry, concentrate in each case. Uh, the most common, the most common. My voice is not clear, Dr. Nagam, or clear?
A bit interrupted.
Interrupted?
Sometimes
Now it is clear.
a bit clear.
Okay.
Okay,
My
we can
advice,
try.
yeah, my advice to all of you: when you finish one case, forget it. Forget it and concentrate in the present case now. Because the most common mistake that all of us we are doing during the hot seats that you are presented with a case and your mind in the last case, the case previous. Really, really, it is very common and it is very, very destructive. Okay, so today we will try to overcome the most common mistake. Uh, Please, Dr. Naam, if my voice is not clear, either text me or WhatsApp. Okay. Let's start our first candidate.
Yes, sir. Good morning, sir.
Good morning, Dr. Naam. Start. 15 minutes.
I'll start, sir.
Doctor, this is adult with knee pain.
Yes, sir. I've been provided with the frontal radiograph of a skeletally mature patient of the knee of the right knee joint. So on my first glance, I can see that there is a expansile, slightly sclerotic lesion noted in the proximal shaft of the fibula. This lesion is expansile and it shows osseous matrix. It has a wide zone of transition. I can see a extensive periosteal reaction, some of which appears interrupted with a sunburst pattern of periosteal reaction. Um, I'm not seeing any obvious, there is a cortical destruction which is not well visualized on the frontal projection. So this is keeping with aggressive bone neoplastic etiology with osseous matrix. So for my top differential would be a osteosarcoma. However, I would also like to look at the lateral image, if possible, lateral X-ray radiograph to look for the soft tissue swelling or any soft tissue extension. Uh, so on the lateral view, I can see that the periosteal reaction is very clear on this, as well as a soft tissue swelling is noted, which seems to be extending into the up to the knee joint. So this is again keeping with extra osseous extension of aggressive bony neoplasm. So my top differential would be an osteosarcoma. Uh, and the second differential could be a sclerotic mets. This would require I would inform these findings to the referring clinician. This would require a referral, orthopedic referral, as well as a referral to the sarcoma discussion in the sarcoma MDT to plan for further management. Also, a chest radiograph may be recommended in case of any possible lung metastasis, which may be present in cases of osteosarcoma.
50-year-old male patient, work as an engineering stone worker, presented with dyspnea.
Okay, I've been provided with a frontal chest radiograph of a 50-year-old patient who has occupational history. Uh, first glance, I can see that there is a ill-defined opacities involving bilateral upper and mid zones, slightly extending into the lower zones on the right side. The opacities are ill-defined with surrounding fibrosis and areas of loosened areas peripheral to it, likely emphysematous changes. So I'm thinking there is also tenting of the diaphragm noted on the left side and slightly on the right side, which could be secondary to volume loss in the lung fields. The cardiac borders are well seen, but there is slight tracheal shift to the right side. Again, could be representing fibrosis and volume loss. So I'm not seeing any obvious bony lesions uh, in the ribs or in the surrounding chest wall. So, given these findings, my first thought would be a fibrosing lung disease with mass-like opacities involving the upper mid zones. So, given the history of occupational history of a stone worker, I'm thinking of possibility of my first differential would be a progressive massive fibrosis secondary to a silicosis, uh, which silicosis, yeah. Other differential could be other causes of occupational disease like cold workers, pneumonicos, but there is no occupational history. And yeah, then last differential, less likely differential. If there was no occupational history, I would have considered an end stage sarcoidosis as well. But my first differential would be a progressive massive fibrosis in case in a underlying fibrotic lung disease.
Okay.
This would require management with referral to the uh, lung respiratory physician for further management. Uh, Also, a co- HRCT of the chest could also be done for further evaluating this lesion. Can I scroll? So, okay. Uh, uh, can I scroll, sir?
Yeah, request control text. Give me a request.
Uh, Sir, I'm
You
not
know?
able to find that
Okay.
option,
Okay.
sir, actually.
Okay.
So on the axial sections of the chest, I can see there is a right-sided pneumothorax, as well as a collapse, slight extensive fibrosis in the right lung. It is associated with areas of diffuse patchy consolidations forming a mass-like lesion with surrounding fibrosis and volume loss. There is surrounding interstitial thickening with slight with areas of fibrosis and mild traction bronchitis also adjacent to it. The lower lobes are not significantly involved. Uh, the pathology is mainly in the upper lobes. I would like to also look at the mediastinal window to look for any calcified lymph nodes, which could be seen in, yeah. So there is multiple lymph nodes, lymphadenopathy involving the paratracheal, hilar, and the aortopulmonary window, which many of which appear calcified. This is keeping with chronic silicosis related lung disease, which usually show calcified lymph nodes. So this my main differential in this case would be a progressive massive fibrosis in an underlying fibrosing lung disease secondary to silicosis. This would require discussion in the, referral to the respiratory physician for further management, and yeah, and also discussion in the lung MDT to plan for a possible which if the the possibility of any lung transplant, which may be considered in end stage disease.
What's your differential diagnosis?
My other differential would be with if there was no history of occupational history, I would consider end stage sarcoidosis, which also presents with fibrosis and fibrotic lung disease involving the upper lobes and calcified lymph nodes as well. And this is an emergency as well, since there is there is right-sided pneumothorax. So this would require urgent management. I would immediately call and inform the referring physician for management of the pneumothorax. This would require a chest tube insertion also to relieve the pneumothorax.
What do you think this amount needed institute?
Sir,
What do you think this amount needed institute?
sir, your voice is not clear, sir.
This amount of pneumothorax need you?
No, no, this sorry, this voice is little blurred, but I think the pneumothorax is very mild, so they would need to clinically evaluate the patient. If the patient is very symptomatic, that would require a chest tube insertion, sir. But
Okay,
otherwise, they would observe the patient.
according to this patient, is patient need or not chest tube?
Sir,
Uh,
yes, sir, this would require chest tube insertion.
what? 9 months male patient. The patient sustained effects on the northern part or require multiple seizures and they become unconscious.
Okay, so I've been provided with axial CT images in subdural window. I can see that there is subdural collections noted along bilateral cerebral convexities. I can also see there is some hyperdense areas in the posterior interhemispheric fissure, which is also extending into the subdural space. It is extending inferiorly along the tentorium cerebelli as well. So this is likely keeping with subdural hematoma. Can see slight amount of hyperdensity on the left side as well. So I would also like to look at the bones to see if there is any fractures. I'm not seeing any obvious intraparenchymal hemorrhages on that study. So looking at the bone window, uh, can see the unfused suture lines. The
10 minutes.
I don't see any obvious fractures on the. Okay, there is okay, that's most of the the bones look predominantly normal. I'm not seeing any obvious fractures, but there is an subdural hemorrhage. So this would require a referral to the neurosurgery MDT, and also the urgent pediatric referral would be required. Now, since there is history of fall and there is a subdural hemorrhage, I would also like to suggest a skeletal screening for the rest of the skeleton to look for any possibility of any non-accidental injury. A skeletal survey would be normally done. I would also inform this to the I would also get a second opinion in this case from a senior radiologist to cross-check these findings, as well as notify the relevant authorities in the hospital regarding my suspicion.
So what's your findings?
This is a case of subdural hemorrhage with extension into the interfalcine region and the tentorium cerebelli with I'm with yeah this so I would still need to rule out the possibility of a non-accidental injury with a skeletal survey before the patient leaves the hospital, since
What about this?
this
You have any doubt? Is
So there is subdural collections noted bilaterally. So this is most likely it could be either chronic subdural hemorrhages, which are low density as
Yes.
subacute or
Yes.
chronic
Yes.
collections,
So,
in subdural collections. So this could be old, related to any old head injury and old subdural hematomas, which have now become isotense to CSF.
so how to confirm?
So, so this is again keeping with the possibility of a non-accident injury, because there is multiple hemorrhages with different ages of bleeding. So this is highly suspicious for non-accidental injury.
Are you sure
So
this is subdural collection? Maybe CSF.
uh, yes, sir, but no, sir, I think this is subdural collection, sir.
Yes, doctor.
This is subdural collection. It is prominent only in the frontal region. So
How
this
to
is causing
confirm,
slight
doctor?
mass. It is
Doctor,
causing slight mass effect.
how to confirm? How to confirm?
So I would
Yes.
mm, I would like to look at the coronal images if available to see for any
What
layering.
else? What else?
Um,
What is your next step?
so next step would be I would this would require a pediatric referral, as well as uh, I would want
What
to
else?
size for a skeletal survey to look for any other
Doctor,
injuries to
doctor,
be.
doctor, patient in your department. What is the next examination on your side?
MRI, sir. I would do an MRI to look for the age of the collection if it is bleeding. So I've been provided with axial T2 weighted images. I can see that there is high T2 high signal intensity extraaxial collection involving both cerebral convexities. It is extraaxial collection, so this is keeping with the subdural collection. I would also like to look at the T1 weighted images to confirm if it's hyper intense. So there is hyperintense blood in the subdural hematoma posteriorly. Anteriorly, the lesion is separate from the CSF. So this is definitely a chronic, subacute to chronic
Thank you,
collection
doctor,
in the.
so
Yes,
much.
sir. Thank you, sir.
You did very well. Take some notes. Your style is amazing. Or say how that was out. But you forget, uh, always you forget the next steps. You didn't ask for MRI, even trying to help you. It is okay. The
Yes, sir.
examiner will not do like this. And honestly, if you didn't request,
Yes, sir.
my voice is not clear or clear.
Sl little blood, sir. Like
My voice clear now.
yes, sir.
So he always asking for manifestation, evaluation, whatever they ask. Is it not necessary? The examiner will tell you, don't worry about it. He didn't ask like this. But as regard to the new patient, you will be presented with how many cases? 3 cases per room. So each case must take 5 minutes, and this is very long time, by the way. So, sure, after X-rays, there are CT or MRI. After CT, there are MRI. So first tip today for all of you, my colleagues, frequently ask. When you ask, even if you presented with MRI, ask for X-ray, especially in MSK. Why? Because calcification and periostal reaction is better seen in X-ray. Okay, my colleague? So
Yes, sir.
expect that most of the cases will be long cases and contain many modalities. In this case, you did very well, but you didn't search for other regions. Apart from you checked the bone window, it's very good. But what is this? What is at least tell the examiner there are widen of CSF. So, doctor, I'm worried about chronic collection. Very good like this. Why is this? Why is this 100% a collection and not just a dilated CSF space? Look here at the gyri and subside. Look at the subside. It is effaced layers. There are
Yes,
mass
sir.
effect here. Okay. So your next step always after CT, especially this is a child abuse. We are doing MRI if there are some neurological symptoms. But here you have image. Okay. So second tip today, when we have a child abuse or accidental injury with hemorrhage, CT hemorrhage, you must ask for MRI with why? Why? Look here. Hemorrhage of different age, acute and subacute and the chronic. See, this is acute. This is subacute. Okay, especially late subacute. Okay, this
Yes, sir.
is maybe chronic. The only tool that will help you to pick up this finding, the MRI. Okay. Second, you did very well about the skeletal survey. But take care. You will take a review by two pediatric radiologists within 24 hours. It's very okay. When
Okay,
you
sir.
see the bone window, okay. If you have time, better to tell the examiner, doctor, there are no occipital or skull-based fracture. Why? Because this is very common in child. Thank you, doctor. For us, case before.
Yes.
You forget here one of the critical signs. Look here, this solution is here not present. Okay, there are a pneumothorax here. Okay,
Yes, sir.
and
Yes, sir.
you didn't ask for CT. I try also here. What is your next step? Asking to what is your next step? Second, see, this is a bilateral, mainly very higher opacity extending to upper and the left middle zone, right middle zone. Okay. Immediately after that, okay, a reasonable doctor intervention is you forget the history here, basically. And you 3 times you are telling if the patient has occupational history, I will give this is BMF or whatever cycle. Already he has. He is engineered to know. So, my colleagues, please don't forget the history. It's very critical. Your differential here, number one, is silicosis. When the examiner give you the other, my voice is clear, my colleague, or not? Wait, okay. Usually, okay, this is the but this is not one minute, it's a long time expression. It's a side. This is the for one time. Okay.
Sir, voice is not clear, sir.
Clear now? It's
Good morning, Dr.
extended. Are you
Good
ready?
morning, Dr. Rami.
No.
Hello,
Yes. Hello.
Dr. Rami, your voice is still muffled.
Okay. Now you can listen to me.
A little bit better.
Okay. This is 45-year-old female patient with left-sided hemiplegia. Can you request control?
Yes. So I'm presented by MRI study axial flare images of 35 years old female patient with left-sided weakness. I'm trying to scroll the images. Really, the scrolling is still there is some difficulty in scrolling. However, it is going now. I'd like to check first from the first image to the last image before for commenting on this scan. Please, Dr. Rami, if you can scroll for me, please, for this one, because there is some difficulty in the scrolling from my side.
Can you use the arrow, please? The sidebar with the arrow.
Yes, I will try to. Yes, I am trying now. Yes, the up and down arrows working. After scrolling the images of the patient, I can see there is evidence of high signal intensity seen within the right-sided internal carotid artery with loss of signal void. I'm scrolling up again to the whole brain images. I can see there is evidence of high signal intensity in the flare within the right-sided centrum semi-oval region, extending to the higher levels of the right-sided hemisphere. Uh, this appearance is representing a watershed area of infarction, which could be caused by internal carotid artery dissection or significant stenosis, the high signal intensity in the right internal carotid artery is mostly in keeping with right internal carotid artery dissection with watershed areas of infarction. As the patient has this acute symptoms, I am worried about worried about also for any hemorrhagic transformations for this patient. I will check the T1 weighted image to confirm if there is any hemorrhage or not. I couldn't see any uh, significant mass effect on the nearby ventricles. It is an emergency. I will flag these images and call the neurology team for urgent management of this patient. I think he is also be transferred to urgently artery dissection. In my routine practice, I will check the MR arteriography while the patient is still in the department, and also to see the area of affection in the internal carotid artery. Doppler ultrasound could be done if there is time, but I think this patient needs rapidly to be managed by the neurology and interventional radiology team for these steps.
Yeah, hello.
Yes, this is coronal images of the same patient. I can see this, I think, T1 FATSAT images. I can see there is evidence of very thin carotid artery, and there is high signal in the upper cervical and also the start of the cranial part of the internal carotid artery, which confirms the diagnosis of right internal carotid artery dissection with watershed infarction. As I told before, it is an emergency. This patient needs to be transferred to the neurology and the neurointerventional radiology team for urgent management of the patient in the ward.
Yeah, please begin.
Please, also, your voice is still muffled. However, I will present this case. I'm presented by frontal radiograph of the pelvis of skeletally immature patient. Uh, from the first look, I can see the most prominent abnormality is the slippage of the left capital femoral epiphysis with widening of the physis and also reduced volume of the left femoral epiphysis, as well as medial and posterior displacement. This I couldn't see any other abnormalities in the other side. It looks normal. Also, the acetabula at both sides is normal, no evidence of fractures. So it is a left-sided slipped capital femoral epiphysis. This needs urgent referral to the orthopedic pediatric consultant for binning in situ. This patient may need MRI study to confirm the other side affected or not, and sometimes they make prophylactic binning of the other side as well.
What is the early stage?
I couldn't hear you clearly, Dr. Rami.
Yes. What is the first or the early sign pre-stage stage in MRI?
Uh, Please, can you repeat again the question? I didn't hear you clear.
My voice is still not clear well.
Yes, yes. If you can raise it a little bit.
What is the early sign pre-stage stage in
Yes, the early sign of pre-slippage is widening of the physis without displacement of the femoral head surface.
what else?
Uh, with which is becomes prominent in the frog leg view, which is recommended in such subtle cases. But this case is prominent left-sided Sufi. The I think also the clearance line not intersect the head epiphysis. This
60-year-old male with chest
yes.
pain.
So I'm presented by frontal chest radiograph of 60 years old patient come with chest pain. I'd like to take a look for this X-ray study. I can see there is evidence of sternotomy wires are noted, and also there is shagging of the cardiac border at both sides with reticulations mainly seen at the perihilar and the basal regions of both lungs. In my routine practice, also I'd like to zoom in the apical zones for any apical areas of pneumothorax. The other thing I can see there is evidence of diffuse bone sclerosis seen, I think, all over the bones of the thoracic cage. Uh, no evidence of pleural effusion. Heart size is quite average. Uh, this patient, in my routine practice, I will check lung apices for any subtle pneumothorax to exclude. And I will ask about history of this patient, if he is long-standing patient on long-standing cardiac patient on treatment. Maybe this basal findings due to amiodarone toxicity. But the skeletal sclerosis, the diffuse bone sclerosis, uh, is not is still questionable for me. So I'd like to do CT scan for this patient, as in this elderly patient it could be diffuse metastasis. Also, I will ask about any history of primary malignancy that could guide me to the cause of this diffuse bone sclerosis. The other causes rather than diffuse sclerotic metastasis is in this old age group is myelofibrosis. I will search for these findings. First, I will ask for CT scan to assess the in bone window and also mediastinal window for the bone findings, and also for the any associated soft tissue or pulmonary problems.
What history do you want?
I didn't get you, Dr. Rami, please. I'm sorry.
What history do you want to ask about?
What? I didn't get you.
What history? What
History,
history
yes, yes.
do you want?
Uh,
Do you want to ask
uh,
about? My
if there is,
history.
if the, yes, if there is any history as this female patient, if there is any history of primary breast cancer or previous uh, surgery like
Okay.
splenectomy, as case of
Okay.
myelofibrosis, or diffuse blood transfusions, as it could be a cause of this diffuse bony sclerosis.
Okay. What do you want to do?
CT scan, CT chest first, and if it will need it, I will complete to CT abdomen and pelvis also for staging if there is any concerning finding in the CT chest.
What else?
Also, bone scan can be done in this patient to confirm the findings. Yes, this is a CT scan of the same patient. This is bone window. I can see there is evidence of diffuse bone sclerosis noted in the ribs and also the dorsal spine. Uh, also there is evidence of mild cardiomegaly as I found in the X-ray. The bone scan showing diffuse bone sclerosis. Bone scan. This is delayed phase MDB bone scan of the same patient showing high uptake in the axial skeleton of the same patient, with mainly affecting the whole spine as well as the sacrum and pelvic regions. The part of the skull also is taking high tracer uptake. There is mild, rather symmetrical high uptake seen in the proximal tibias. The kidneys is still seen, so it is not a super scan. The possibility of metastatic sclerotic lesions is still in the as a first possibility in this patient, as it is affecting mainly the axial skeleton, which is characteristic for malignant osteoblastic activity. Hello? Romy, I couldn't get you, please.
What's your final day?
So my final diagnosis, it is a case of diffuse bone sclerosis, which is most likely the metastatic sclerotic bone disease. Still, I couldn't detect the primary malignancy, so this patient should be referred to the CUP MDT, cancer of unknown primary, MDT meeting for discussion of the possible primary, sending to these places. The most common primary sending sclerotic metastasis in female patient, breast and transitional cell carcinoma, as well as lymphoma. PET CT scan could be beneficial in yes. Yes, but I didn't mention because I show breast shadow in the X-ray. That is why I'm suspecting this female patient.
No problem. Either you can ask the examiner. Can you hear
Yes,
me well?
yes,
Can you hear
yes,
me?
yes. Now, a little bit better than before.
First, I said over 60 males. It is
Uh,
great.
you, your voice is lost again, Dr. Rob.
Okay. My colleague was a male patient. Okay. So it was a prostatic cancer.
Is clear now?
Yes, yes. Now better.
Yeah. So no problem. At least you pick up the main idea. This is a metastatic sclerotic metastatic disease. Okay. My advice to you to read the scenarios, the case from the beginning. All each is in harder. And I mentioned, when I mentioned from the beginning, all each patient with chest pain. You find this sclerotic one example calculation. So you must concentrate the sclerotic power. Don't talk, just mention this calculation as a side one. And you didn't ask for this one. This one was the key. See, in this age, it must be osteopenic. See, look, even you can't see the tumor here. Okay?
Yeah.
So, so it is a sclerotic metastasis. You ask for CT. Don't talk too much about this is confirmed. If it's a confirmed the finding, I will go scan. This is understandable. So this is a super scan. Where is the kidney? The kidney is very muscle. But look here. Look here. Where is the soft tissue? Okay, there are some cases of the kidney, but this is not the kidney that we see in the scan. So this is a super scan. Okay. The cases will not sharply 100% typical like in the box. It's almost super scan. Okay.
Yes.
Is it clear?
Yes, yes, clear.
You need this one thing. You got what? The earliest sign. The earliest sign. Why we do MRI for contract sign? To pick up any pre-existing edema. And this is the earliest sign pre-slippage stage. This is the earliest sign because it looks like okay.
Yes.
The first case. I have no commentary. But was West finished. In a case like this, we begin request. Okay, the problem is the voice. So should let's start.
No problem.
Okay, what happened here? The feedback again for our exit. What happened? He find some signal abnormality and then confirmed it by other sequences, either EDC, loss of signal, or dark signal in EDC, and the bright signal in diffusion and the location in watershed area. Okay. Then excellently, he pick up this abnormal signal, which is a sign of the right ICA dissection. You must request MRA. You must. Even if the examiner didn't give you, you save yourself. Okay, my colleagues, this is a protocol. You must fulfill it. This case, left-sided Sufi, I ask about the pre-sleep stage or why you are doing why doing MRI for this contralateral side, because we detect the pre-slippage stage. How? Edema. Pre-physial edema. This is the most complete sign. Okay, this is clear. The case before, it was a male patient, and I mentioned, so take care again and again from the history. And it's a patient in his old age, and you find all sclerosis, concentrate because it is generalized. Then he asks CT. The CT confirms the finding, and you must ask for bone scan. This is a super scan. Why? The kidney is very big. This is not the normal kidney. There are most of tissue uptake at all. Somebody will tell me, doctor, but the kidney have some traces. Okay, be intelligent. Read the scenario. The examiner gave me old patient X-ray, which shows sclerosis. Then there are bone scan. The case expresses itself. The case run in the way of super scan. Okay. Even you can tell the examiner almost this is super scan like this. Okay, my colleagues. I told you many times before, expect the next step. Expect what is in the mind of the examiner and look at the examiner eye. We all of us are human beings. Really, and you will become something really emotional, especially the examiner. And you see that I will again. You want the case before. On the case. According the feedback of our first candidate. Take care from the voice good now. You can hear me now, my colleagues. Okay. The first candidate, he did also very well, but don't use the term expansile here. This is not expansile, it's sclerotic aggressive lesion. Okay? Sclerotic expansile lesion. Number two, the patient is young. So it's also sarcoma, Ewing sarcoma, like this. Don't assess as a second differential. Is that clear? Case number two, you forget the history. Despite I mentioned the patient working as an engineering of stone mining. So you must keep the history very well, very well. And don't forget these lessons. Second, the amount of pneumothorax is fine, so it can treat it conservatively. This is the only 2 points of view. You must give also at least another differential diagnosis. Even you can use the term less likely to be similar, but due to the history, it is almost same, like this. Just because of our first candidate, take care from this one. Bilateral submural collection with mass effectively for the subside phase in any patient with non-unexpected head injury, and you find hemorrhage here, you don't know, you see well with the acute. To detect other chronic and subacute, you must ask for MRI. It's very critical. Okay, so the next feedback of our why not CSF space? One colleague asked. Okay, my colleague, look, where is the sulci here? Where the sulci is phased, compressed. Even look here at by the MRI. Look, this is collection. It must exert any type of mass effect. Even if you told the examiner this is prominent than usual, I'm worried about being chronic subacute hemorrhage. Okay, I will be happy. Okay, all of these terms is accepted. Thank you, everyone. So, I'm sorry for these technical problems. One very important question somebody sent during the field. No, you must know this. It's very important. This is the first question you may be asking, or this is the first word you must say. That's it. This exam MRI. So, last candidate. Last
Hello,
candidate.
Assalamualaikum, sir. Can you hear me, please?
Yeah,
Yes,
I
sir.
can hear you.
Sir, I'm on my mobile because of internet connection. I couldn't able to connect my laptop. Sir,
Okay. I will repeat again. The sequences will not appeal on the exam. You must tell the examiner I'm presented with axial, like axial T1 with MRI sequence, or coronal T2, or posterior, like this. Which is very important. Okay, and he is if you didn't tell, he will ask. This is 40-year-old female patient presented with acute abdominal pain.
I'm presented with the CT post-contrast photovenous phase axial images of a patient, 40-year-old, presented with abdominal pain. I can appreciate that there is heterogeneous enhancement of the liver parenchyma, giving nutmeg appearance. The liver is enhancing more centrally than at the peripherally. And I can appreciate that there is a hypodense thrombus, which is seen involving the intrahepatic part of the inferior vena cava. And I cannot appreciate hepatic veins. And there is mild right-sided pleural effusion and mild abdominopelvic ascites. I am looking at the porta hepatis collaterals. I cannot appreciate any porta hepatis collaterals. Spleen is mildly enlarged. The portal vein and its branches are patent. I am looking at the kidneys. Yes, the rest of the abdominal structures are normal. So keeping in view the thrombosis of the intrahepatic part of the inferior vena cava and non-visualization of the hepatic veins, I'm concerned that patient is having Budd-Chiari syndrome. And as the collaterals have not developed, spleen is borderline enlarged. So this is likely in a case of acute Budd-Chiari with mild abdominopelvic ascites and right-sided pleural effusion. I will immediately inform my finding to the so there is fluid which is noted in the region of porta hepatis with mild gallbladder wall edema. Sir, there is edema of the periportal tracts.
Okay, what is this? What is the name of this lobe?
Sir, this is the quadrant lobe, which is showing normal enhancement with no evidence of any heterogeneous enhancement. So this is spared because it has separate
What is
supply.
the next step?
Sir, I will inform the finding immediately to the referring clinician and refer the patient to the gastroenterology team for bypassing the raised venous pressure by doing the transhepatic
Thank you. 45-year-old. 45-year.
hepatic cortisol shunt. Yes, sir.
Thank you. 45-year-old male patient after road traffic trauma.
Okay, I'm presented with PD images or axial images of the right shoulder joint. After the patient presented to me with trauma, I can see that there is mild joint pain and there is hyperintense signals noted along the anterior aspect of anteroinferior labrum. And I can also see that there are hyperintense signals in the humeral head as well. Let me see. Sir, can I see this in the coronal images? PD or FRCR coronal images, yes. So there is mild edema of the humeral head and neck, and there is mild irregularity of the inferior part of the humeral head with the labral tear noted along the superior margin of the glenoid. So I'm concerned that patient is having reverse Hill-Sachs deformity with the postero-superior part of the glenoid labral injury and mild joint affair. The patient
Look here, please.
is likely having...
1 second. 1 second. Look
Yes,
here,
sir.
please.
Sir, there is depression in the humeral head with associated marrow edema.
Where?
And I can
Where?
see that this is involving the anteroinferior part.
Okay. And what else?
Sir, focal hyperintense signals are noted along the glenoid labrum, which is
Okay.
involving the posterior part, posterior-superior part, not anteroinferior part.
Are you sure?
Here. Yes, sir, I
Are
can
you
see a
sure?
linear hyperintense lines. Yes, sir.
So what's your final diagnosis?
So this is a reverse Hill-Sachs lesion with the posterior superior cartilaginous Bankart lesion. So I will inform the finding immediately to the referring clinician and refer the patient to the orthopedic team for further management. There was no associated ligamentous injury, so I will mention these findings too.
Thank you. 30-year-old female patient who was chronic cough listening.
I'm presented with the CT chest prone images of a patient presented to me with a chronic cough. I can appreciate that there is mild to moderate dilatation of the bronchi with volume loss of the left lung. The bronchi are thick-walled. Some of them shows tramline and some of them shows secular configuration. I can see that there are few fibrotic strands noted in the left upper zone with mild volume loss. Right lung volume is so this is a prone image, so I can, yes. So the right lung volume is relatively preserved. A couple of nodules are also noted along the pleura inferiorly. There is no associated pleural effusion or ground glass attenuation. I would like to see the mediastinal window to comment on any enlarged lymph nodes. A couple of small mediastinal lymph nodes are noted. Sir, I would like to see the cardiac apex, whether this is on the right or left side. Yes, the cardiac apex is on the left side and liver is on the right side. So this is in keeping with the bronchiectatic changes, predominantly involving the left lung. I would like to ask if there is any history of previous multiple recurrent admissions to the hospital. Then this patient is a case of cystic fibrosis.
Yes.
And
Yes.
if the patient, Yes, then this is confirming my diagnosis of cystic fibrosis. The secondary differential in this case could be idiopathic bronchiectasis secondary to some mucociliary dysfunction. I would like to ask the referring clinician about the serum sweat chloride test, whether it's positive or not, and will refer
Look
the
here,
patient to
please.
the.
Look here.
Sir, I can. Yes, sir. I can see that the pancreas is showing fatty atrophy, and there are a couple of calcific foci noted in the region of gallbladder, I guess. No, there are no
What's your
calcific
final
foci.
diagnosis?
Sir, this is a case of
What's
cystic
your
fibrosis with this is a case of cystic fibrosis with bronchiectasis in the lungs and fatty atrophy of the pancreatic parenchyma in the abdomen. I will inform the
what will you
finding,
do
refer the
next?
patient to the pediatric. I will inform the finding to the referring clinician and refer the patient to the pulmonologist for further management of ongoing acute exacerbation of the ongoing cystic fibrosis with some bacterial pneumonia.
45-year-old female patient with palpable mass.
So I'm presented with a mammogram of a female patient in which there is fibroglandular breast parenchyma noted bilaterally, and the density is more pronounced in the upper outer quadrants. That I would like to see the CC view as well to before commenting.
Please, my colleague, don't use the marker. Use steroid session. Please, my colleague, don't rotate at the screen, please. Go on.
So here I'm provided with the craniocaudal view of the bilateral breast of a patient presented to me with the palpable lump. So I can see that the retroareolar density of the left breast is increased, and there are few nodular areas noted in the left breast parenchyma. I cannot discretely appreciate any solid mass. I would like to see this on the right and left mediolateral oblique view as well before proceeding to the next study. So I would like to see the mediolateral oblique view of bilateral breast. So this is also showing that the left breast upper outer quadrant density is diffusely increased with irregularity of the parenchyma and multiple nodules of variable sizes merging with the breast parenchyma. The nipple is seems retracted inwards on the left side, as I cannot appreciate the nipple shadow. So I'm concerned that patient is having left breast mass with perifocal speculations. I would proceed the study with ultrasound to confirm the diagnosis, and then we'll advise next investigation. Sir, I would like to see the ultrasound.
Before ultrasound in mammography, what should you do?
I can perform the magnification views or coned view of the left breast to see any microcalcification or perifocal speculations. Yes, on coned view, I can appreciate that there is architectural distortion of the left breast parenchyma in the retroareolar region. So I'm quite suspicious of some malignant mass in the left breast. So I will proceed to study with the ultrasound. I cannot appreciate any microcalcifications in it. So I would like to see the ultrasound.
Again, describe the finding.
Sir, on the mediolateral, on the left craniocaudal coned magnified view, I can appreciate that there is a solid radiodense lesion noted in the retroareolar region, as I already mentioned, with perifocal speculations. And this lesion is causing surrounding breast parenchymal distortion. And I can appreciate very tiny, couple of small foci of calcification in the center of the lesion. So I'm quite suspicious about the malignant left breast mass. I will proceed the study further with ultrasound. Yes, this ultrasound image taken through the linear high resolution probe shows a solid irregular outlined mass with perifocal, with perilesional distortion, breast parenchymal edema, and focal skin thickening just above the lesion. So this is a case of malignant left breast mass. I will refer the patient to the one-stop breast clinic for further investigations like ultrasound-guided breast biopsy of the patient, further procedure study with the MRI to rule out any multifocality, to comment on the axillary lymph node status, to comment on the chest wall metastasis, and will refer the patient to the oncology breast multidisciplinary team for further management.
70-year-old male patient, heavy smoker, presented with first seizure.
So I am presented with the CT brain plain images of a 70-year-old male patient, in which there is, I can see there is a diffuse hypodensity involving the left posterior parietal and left occipital lobe. This is involving predominantly the white matter, but also extending to the subcortical white matter as well. I can see that there is mild effacement of the left occipital horn. The sulcus spaces are relatively maintained, and there is associated mild cerebral atrophy. I'm concerned that patient is, sir, I would like to see the base of the skull images to rule out, as I'm suspicious of some ischemic injury to the white matter of the posterior parietal occipital lobe. Further, I will proceed the study with the CT brain with contrast or CT angiography to further comment on any filling defect in the region of the posterior cerebral artery to rule out
Have a look
ischemic
here,
stroke.
please. Could you have a look, please, here?
Yeah, yes, sir. I can see that there is focal edema of the posterior parietal and occipital lobe, and there is focal hypodensity. Sir, I would like to change the density a little bit, or would like to proceed the study with MRI. On MRI, T1 post-contrast images are provided, and there is
What's your
enhanced
diagnosis?
solid lesion.
What's your
Sir,
diagnosis?
this is an extra axial lesion, which is noted in the region of the left occipital lobe, causing secondary mass effect over the brain parenchyma. So,
Yes, sir.
sir, before proceeding to the diagnosis, I would like to see the differentiated images as well, because I'm concerned that patient is likely having dural-based meningioma. I would like to
What
confirm
else?
this on the DWI.
What else could you
Sir,
think?
this
Could
can
you think? Could you think meningioma will cause this severe edema? What else?
sir, this can be a case of brain metastasis as the patient is old age.
Okay, what's
This
your
can,
next step?
yes. Sir, I will ask about any history of primary malignancy, and if the patient is not a known case, then I will inform the finding to the referring clinician. Will advise the
What
CT neck,
is-
chest, abdomen, pelvis to look for the primary, and chest X-ray as the patient is smoker. Yes.
Okay, excellent.
As a patient smoker, so this can be a solitary metastasis from the lung. Yes. On the CT images provided to me, I can see that there is a solid spiculated mass noted in the left lung apex with perifocal spiculations and parenchymal infiltration. So this is confirming that the patient is having solitary metastasis in the brain from the
Thank you
left
so
lung
much.
cancer.
Thank you so much. 15-minute best. Thank you so much. It was a case of metastatic brain tumors. Okay, look here. Look here. Don't miss this one. The edema take your eye. I know. Don't miss. Okay. And first possibility in old age. Why I told you he's a heavy smoker? Why? To put metastatic bronchogenic carcinoma as a first differential. Okay. So my colleague, don't forget that. Very critical in the exam. When we do post-contrast MRI, see, look here. The meningioma typically or most commonly didn't cause this large edema. Okay? Didn't cause all of this large edema. So search for another causes, especially when the patient is 70, heavy smoker, and seizures. Seizures means something new. Seizures means something do a brain insult. And most of the meningioma is silent for a long time. You did very well when you ask either for chest X-ray or CT chest. This is Very good. At least there are a bronchogenic carcinoma and a destructive lesion here, and there are no time to examine the rest of the exam. There are multiple large packets. Okay, you did very well. This case ready. This case, it was a breast carcinoma. Take care in this dense breast to ask for magnifying view, especially here. What happened here? This is very dense, thick skin and retracted nipple. Okay, it may be technically, I know, it may be technically, but compared with the other side, there are here no second skin, but here there are second skin. So the key here was this magnifying foam film. There are speculating mass with tiny or micro calcification. Very important. This case from the beginning, okay, if you wait to figure out the changes, but I'm waiting from you which lobe is more affected. Apical, both apical lobes. Second lobe has a mediastinum. You should ask the exam doctor, I wonder to will have any pancreatic hypertrophy, fatty infiltration, fatty replacement. No pancreas here. Why? This is a splenic vein. This is the expected location of pancreas totally replaced with fat. Okay, this is a very common, very important case. Cystic fibrosis with pancreatic fat replacement. Okay, this case you did very well. It was about Kairi, but I ask you what is this? This is the hypertrophied caudate lobe. And the caudate lobe is completely normal. Why? Because it had a separate venous drainage away from the life. Okay, my colleagues, is it clear for all of you? Any question? Any question, my colleagues? Thank you so much. Sorry for today. I will upload the video after editing. Post-sarcoma. Okay. After editing. Thank you so much. Thank you, Dr. Lahata. To the somebody ask about the last CT. The last CT. The last CT was about Kairi syndrome. But Kairi syndrome. This heterogeneous not make appearance or dirty liver appearance with hypertrophied. Okay, that is all. And sure, there are thrombosis here. Look here. This is the IVC. Look down and above, you will see is ossified. Only this interhepatic segment is even look here. Supracardiac segment is. Thank you for all of you, colleagues.